Thank you so much. I am so excited to be here today. First of all, I was nodding vigorously so much during the last panel. I feel like I have whiplash. And as I looked around, I feel like everyone was doing the same thing. It was just so validating and validating from my own personal experiences, validating for what I see in the clinic, validating what we see in the migraine community all around. So it was just wonderful. And then I'm also excited to be up here with like some of my absolute besties. I absolutely am inspired every day by Dr. Arca and Dr. Townsend. So it's just fabulous. And what we really want to talk about during today's this panel is really talk about the experience of migraine and how it is really this full body experience. And it's not just the individual migraine attack, but really it's the disease of migraine that exists every single day, every single moment, whether you're having an attack or not. Now, as was mentioned in the prior panel, we love a lot of analogies. And one of the analogies I talk to my patients about, and I actually talk to my trainees about as well, is that often within the medical community and definitely within the patient and the lay public community, we think about migraine as migraines with an S. I have migraines. I have 8 migraines per month. I had a migraine yesterday. I don't have migraine today. Migraine is a neurologic disease, a genetic neurologic disease, as was mentioned by Dr. Hawker, saying the DNA abnormalities don't jump in and out of your body on a day-to-day basis. It's there every single day. And so just like asthma is a pulmonary disease that is there every day, an individual have attacks maybe only a couple times a year, a couple times a month, and other people who have asthma symptoms on a daily basis. In people with migraine, huge spectrum of disease as well. People may have a couple attacks a year, a couple attacks a month. Many people have migraine symptoms on a daily basis. But regardless, everyone with migraine has the neurologic genetic disease of migraine every single day, and they'll have migraine attacks where there's symptom exacerbation. So the migraine experience, this full body experience, is something that is present every single day, right? And often my patients will tell me, and I will also talk to them about this, and I'm going to have them audience participation in this. We always say, migraine is not just a headache. Exactly. And in the past, that was thought, what we were saying by saying migraine is not just a headache is that we were saying migraine is more disabling than just a headache. But when I say migraine is not just a headache, what I mean by that is that migraine is not just about head pain. In fact, I have patients who have migraine who may not have head pain whatsoever. In fact, I have patients who have migraine where their head pain may be a symptom, but it's not as disabling as many of the other symptoms. So I like to describe migraine to my patients as a sensory processing disorder. It's abnormal processing of different sensations. And yes, it's true that most commonly people with migraine will have abnormal processing of pain, but also light, sound, smell, motion, touch, all of those things, right? And so that's what we're going to focus on today is really that full body migraine experience. And so we're going to touch, and it was mentioned, central sensitization and autonomic nervous system was mentioned during the last panel. And we want to first level set a little bit by talking about some definitions. So first, we'll start with you, Dr. Arca. Tell us a little bit about what is the autonomic nervous system? So, if I can keep talking, they'll probably turn it on. Not yet.
Not yet. Nope. There we go. Okay. So the autonomic nervous system is like our automatic nervous system. It controls the things that we don't have to tell our body to do, like our heart beating, our breathing, how things move through our gut, how our blood vessels constrict or dilate, things that we would be in trouble if we had to remind our body to do them. Again, it's just our automatic processing. And our autonomic nervous system is divided in a couple of different ways. We talk about the central autonomic nervous system, that's our brain and our spinal cord. And then there's the peripheral autonomic nervous system, and that's the nerves that exit the spinal cord and go to the heart, go to the lungs, the blood vessels, the gut, etc. For the purposes of today, we're mostly going to be talking about the central autonomic nervous system and the parts of that that overlap with migraine. Actually, there's a huge overlap with all the parts of the central autonomic nervous system and the same parts of the brain that are involved in pain processing in migraine. So it's no surprise that there are tons of autonomic symptoms in migraine. And then the other way that you will hear the autonomic nervous system referred to is the sympathetic nervous system and the parasympathetic nervous system. Sympathetic is typically referred to as that fight or flight, and then parasympathetic is typically that rest or digest. So those are some of the terms that we'll be referring to throughout our discussion.
Excellent. Thank you so much. You know, one thing that struck me in the last panel is how Dr. Stanford was talking about how the retention of adipose tissue is an evolutionary aspect, right? That it's protective. And similarly with the autonomic nervous system, right? I think, you know, fight or flight nervous system being overactivated is also something is protective and definitely was more protective in the caveman days. So I always tell my patients with migraine, you guys are superheroes. We don't need those superhero skills as much anymore in current day. But that's my theory as to why there are so many people with migraine. Because even though it's so disabling, right? If 1 in 5 women have migraine, how is it that something so disabling is so common? Well, because we were the survivors in the caveman days. We are the survivors, right? We are the superheroes, but unfortunately, we need to learn how to try to tone down those superhero skills, right? So let's talk a little bit about central sensitization, which plays into this so much. So first of all, Dr. Townsend, can you kind of define central sensitization and then go ahead and jump in as to how central sensitization and the HPA axis kind of plays into each other?
Absolutely. Central sensitization is not a new concept. It was first coined in the 1980s, but unfortunately, it kind of hung out in science research and did not move to better understand chronic pain. The first idea is recognizing our brain constantly changes based on our experiences. If you're a musician, your brain responds to music differently than a person who's not a musician. You can actually see that. The idea before was your brain, you're born with it, it grows a lot, and somewhere in the 30s it stops, and good luck with the rest. Now they recognize, no, our experiences, including as we're older, why we need to continue to have experiences, not in front of the television, but engagement with people and our connection. So our nervous system, our central nervous system, is constantly doing this to help us adapt to survive and thrive in our world. In central sensitization, in this system, all of the inputs that can happen is as your system is getting inputs from the periphery, so lights, sounds, smells, interoceptive experiences, feelings of fatigue, feelings of hunger, all of those sensations go through your system so your brain can make sense of it to then alert the rest of your brain what it needs to respond, including if it's a threat. It will go to the threat processing areas of your brain, the ones that also help you remember where you've previously experienced pain so you don't touch the stove again. And then goes to the frontal part of your brain that will say, hey, is this a threat? No, stand down. Or big threat, pay attention. So in the central sensitization process, what happens is this system gets efficient in ways that you didn't mean for it to, you didn't want it to, and it gets effective. And the reason I always emphasize the word efficient is because some people take the word sensitive and they assume it's an emotional sensitivity, somehow you're being dramatic. It's not. It literally, when they first started studying, it's a nerve cell firing at a lower threshold of provoking. So a threshold of lights or a clapping that previously would not have sent anything now sends quickly. So before, 1 + 1 started equaling 3, and then now 1 + 1 starts to equal 8, right? So in that process too, as we kind of go from there on trying to understand, there's a part of it, so it's connected to and runs parallel with the autonomic nervous system is the stress response system, hypothalamus, pituitary, adrenal. So our endocrine system responds to threats, helps us navigate the gas and the brake. It's called the HPA axis, hypothalamus, pituitary, adrenal response. And in that system, it helps a cascade of the endocrine responses to help send those signals. That's how it's supposed to work. And we all have that, and it works well until it doesn't. When that system becomes dysregulated, what happens is any of the signals coming into our nervous system become amplified. So at the dorsal horn, where it's starting to go into the nervous system, we start to see changes in the mast cell, so the infection response, so the inflammation response, and that's where 1 + 1 = 8. Why does that happen? So when that system becomes dysregulated, there's a number of different factors that we've learned over time. One of the first early ones, some of these there's more research, other ones certainly clinically I've seen, but think of hits to this system across your lifetime. So in chronicity, chronically, or even simultaneously. So first of all, genetics, there's more that we're going to continue to learn where you're prone already to experience experiences at some level. You can sometimes see it in family lines. It might not be presenting in the same pain site, the same anatomy. Someone might have fibromyalgia, someone else might have migraine, someone else might have a lot of osteoarthritis. So it's not necessarily the same site. And sometimes I see records kind of miss that, and they recognize a lot of family members have chronic pain, just not the same site. So genetics. Children, so pediatric pain, surgeries, injuries at young ages when the nervous system is forming. 20 to 30% of individuals who have surgeries at young ages are more likely to develop chronic pain later. Women, because of hormone fluctuations, and including at times of start of menses, a lot of symptoms, pain symptoms that are often minimized, ignored, just pushed through, stop complaining. So again, we have a normative system, kind of a nervous system that's early in formation at the same time of a lot of fluctuations in hormones. Move forward to any hits, injuries to this nervous system, motor vehicle accidents, concussions, traumas, surgeries, infections, including surgeries that there was no complication, there was no infection. It's still a hit to this system. Any types of trauma, any types of abuse, any type of experiences, okay? So I'll include all of you to just do me a favor and breathe, because half of you, I can always tell by the time I get to this point, nobody's breathing. Because you're already tallying up in your brain. So that's called somatic awareness. Notice that you're not breathing. Then I'll continue. Okay. So as we go from there, if you ever in childhood, adulthood, ever had to survive your environment, whether it was because of lack of resources, food, are the lights going to be turned off? Are we going to be evicted? Is our neighborhood not safe? How about within your home? If the individuals had untreated mental illness, untreated substance use, you had to be vigilant. Friend or foe, safe or unsafe, good mood today, bad mood today. Are they going to be angry? What's their jaw set? What's going to happen? So as you're navigating, trying to either save, protect yourself or those around you. Okay, keep breathing. Individuals, so again, whether it's untreated mental illness, untreated substance use, individuals who, personality factors, my high achievement, striving perfectionist, yeah, all right, yes. You wind up trying to take this much resources and stretch it this far, which is possible, and you get rewarded so much that you get asked to do more. And then, matter of fact, you get so good at it that all you need to do now to burn all the candles is to sleep less, eat less well, take less care of yourself, and take on more. So again, we have a lifestyle that actually winds up in that survivalitude and our
I love how everyone is not making eye contact with Dr. Townsend right now.
I'm seeing both. I'm seeing like completely like moving to the floor as well as like looking at me in the eye. You're like, oh my gosh, yes. So that type of lifestyle, my caregivers, oh my goodness, my lovely people who take care of the people around them, either professionally or in your world, you know, and maybe by your own survival stories, you know the needs and emotions of everyone in the room before they even know that they have them. And you can meet those needs. Matter of fact, there's only one person in the room that you're not aware of that needs something right then. And that's usually yourself. So then what happens is we wind up going thirsty for longer, and you're like, I'll take care of that later. So combinations of a lot of those Then what can happen is cumulative, or again, sometimes you get the 1-2 punch at one time. You had the infection, the surgery at the same time that you got the bankruptcy on top of the motor vehicle accident, on top of the, the argument with your boss or whomever. And what can happen is this stress response system, gas and brake, stress, balancing out becomes dysregulated. And that's why things that don't make sense, that people unfortunately in this lack of education were never told and explained. This is when a 12-mile per hour accident can lead to high impact, debilitating chronic pain. That people say, you're just trying to get disability, you're just trying to get drugs, all the stigmas, unfortunately. Or why all of a sudden, oh, okay, I can't be around someone because they just washed their hair 3 hours ago and I can still smell it. And so all the sensory inputs, again, now 1 + 1 = 8. Sometimes in more recently, we've seen a lot of people with onset of chronic pain post pretty unremarkable courses of COVID. Guillain-Barré, West Nile is just because, again, a hit on top of a series of other hits wind up then amplifying. And by the incident, it's not remarkable. Everyone in medical is like, it doesn't make sense. Why would that trigger such a big, high impact chronic pain syndrome? Well, when you take a look across the history, then you can start to see those.
Yeah, that's excellent. And it just explains so much, even when I was learning about central sensitization in medical school, it's always focused on pain. And what I've really learned from you and the literature is about, and see in the clinic, is that it's really all the sensory inputs that are coming in. And I like how you also said the interoceptive, right? About like the way that we're feeling our organs, what feels inside. And that's also an invisible part that a lot of our patients will talk about.
I always tell people, you're not crazy, your nervous system is. Because as a health psychologist, most people will think, oh, we're sending you, you got to go to the health psychologist because someone thinks you're crazy, you're broken, you're not mentally have the fortitude. It's like, no, that's not why you're seeing me. We got to figure out a bigger lifestyle plan to help try to reverse some levels of this, re-regulate the HPA axis.
Yeah, so I always send them to you, and I say, she's going to help retrain that central sensitization parts of the brain and nervous system. So tell us a little bit too about how when patients are experiencing multiple different pain conditions, how that can complicate and add to that whole 1 + 1 is not even 8 anymore, but 1 + 1 starts equaling closer to 100.
Absolutely. The hard part about that, most of my people have more than one type of pain. So when someone has one, I'm like, are you sure? I'm like, are you sure? It's because the whole system, the threat response areas of our entire system, they are so efficient that oftentimes it will be presenting in multiple areas of vulnerability, honestly. So I'll, have headaches with migraines, with fibromyalgia, or maybe something was like, I was fine. My fibromyalgia was diagnosed 20 years ago and it's fine. Then all of a sudden, since this point, something's been the amplitude. Part of it is because that system was already sensitized. And it's in the areas of the brain, again, I keep using the word already efficient, already effective. It's like, oh, I remember this before. Yeah, we're going to go ahead and bring it. Matter of fact, we have so many signals coming in. If I had someone keep coming, we have a little emergency need out here. We have a little emergency need out here. Pretty soon, someone's going to give me a door wedge to hold that door open so we can get the signals faster. This is how our brain, our nervous system is evolved to help us get those signals faster, so it's less impeded. And matter of fact, it doesn't even need to be the same as the original. Now it can be kind of, sort of, maybe close enough. And then the system will start to kick up that high threat response. Now, the second part of that's of course uncomfortable. Everyone wants to avoid any experience. What set it off before? So then we start to see avoidance. Well, this set it off, so now I'm avoid this. My world gets smaller. Unfortunately, in a world that gets smaller, the thing that gets louder is your nervous system, which now does not actually have capacity to tolerate normal sensations and experiences. And so now, so oftentimes, sometimes I'll see individuals and they have, of course, understandable, the headache, the hats, the sunglasses indoors. And what happens, unfortunately, is then now normal inputs of sensory input, light, smell, sounds, actually activate And we actually have to go in the opposite direction. So it has to be thoughtful and methodical, but part of it is we're trying to help the nervous system learn what is safe again, and we have to start gently pushing the walls back out.
Excellent. And of course, we've talked about threat and the fight or flight system. So Dr. Arca, can you please talk to us a little bit about how the autonomic nervous system is involved in migraine, and then also how it just, gosh, adds so much gasoline onto this whole component of central sensitization and the door being wide open?
Yeah, so the autonomic nervous system is inherently involved in the genesis of migraine. So, in the underlying pathophysiology, you can't have a migraine attack and you can't have migraine disease without involvement of the autonomic nervous system. It starts in the hypothalamus. Signals are then transmitted to areas in the brainstem that are these autonomic centers of the brain. From there, additional signals are sent out to other autonomic centers, things that can manifest in things that we can see. So sometimes people experiencing a migraine attack will have pupillary abnormalities or might have a little bit of eyelid drooping or things like that. It can contribute to some of the symptoms that you might experience during migraine. So even some of the nausea, vomiting, and things like that might actually be due to gastroparesis, so slowing of the emptying of the stomach during a migraine attack. So all of this is because of involvement of the autonomic nervous system. So I like to think about the autonomic nervous system involvement in migraine, both ictally, so ictally meaning during that migraine attack, but the autonomic nervous system is still involved interictally, so without having a migraine attack. So like Dr. Starling was saying, remember, you still have the disease migraine, even though you're not experiencing an active migraine attack. So there can still be autonomic dysfunction outside of migraine attacks as well. And the way that that's going to manifest is going to be different person to person, just like migraine disease is going to look very different person to person. And so I think one of the big things that I wanted to talk about in this conference is one of the conditions that I see very frequently overlapping with migraine, and that's a syndrome of orthostatic intolerance. And many of you might be familiar with POTS, which is postural orthostatic tachycardia syndrome. It's called POTS. And in this condition, people experience a lot of lightheadedness, dizziness, might even faint when they stand up. And this is driven by a high heart rate response with standing. Even if people don't meet this specific criteria for POTS, which is an elevated heart rate of 30 beats or more with standing, people with migraine still might have this symptom of orthostatic intolerance. Again, outside of migraine attacks, it might be worse when they're having a migraine attack and might worsen their headache when they're having a migraine attack as well. But again, this speaks to that disrupted autonomic nervous system. And what I see in my practice is, I'd say, I don't want to say 100%, but I'd say almost every single patient of mine with POTS has some type of headache disorder, and most of the time it's migraine. The interesting part, though, is not everybody with migraine has POTS, and not everybody with migraine has symptoms of orthostatic intolerance. And again, that speaks to that heterogeneity of how migraine disease presents itself. So there's just so many ways that the autonomic nervous system can be disrupted in people with migraine.
Thank you so much. And you mentioned a couple things too, in that comorbidity of POTS and migraine. There's also a lot of individuals with gastric dysmotility and Ehlers-Danlos. Can you speak to a little bit about those different conditions, which kind of ties in often with POTS and migraine?
Yeah, so a lot of people speak about like the triad of disorders, and that might be like POTS, Ehlers-Danlos syndrome, which is abbreviated EDS, and then things like MCAS, which is mast cell activation disorder. But it's so much more than a triad. It's more like a pentad or an octad, or the more that we're learning about this, there's 12, 15, 20, I mean, that's why this whole conference exists, right? Is because of all of these overlapping conditions that exist. Anytime I'm seeing a patient in my autonomic clinic, I'm basically screening for all of these things, whether it's in the questions that I'm asking my patients or during a physical exam, screening for joint hypermobility. Because having a greater understanding of all of these conditions that might be in one patient can help me as the neurologist be able to address the things that I can address as a neurologist, and then also get my patients the right referrals to other specialists that can help address these other conditions. So things like EDS or Ehlers-Danlos syndrome, most of the time, the most common is the benign joint hypermobility, although there are other etiologies that have vascular disease associated with it. So it's important to screen and to get vascular screening for these patients, even though the vascular etiologies are more rare. But we definitely see a lot of that in people with POTS, and it can worsen symptoms because if we think about our connective tissues, and if those are more stretchy and hypermobile, well, we still have connective tissues around our blood vessels as well. So if our blood vessels are also a little bit more stretchy, that might contribute to more blood pooling and things. So that could kind of overall worsen POTS symptoms, make people more prone to blood pooling, et cetera. So that's probably why we see a lot of joint hypermobility, Ehlers-Danlos in our POTS population. I do see a lot of mast cell activation, or at least just mast cell hyperreactivity in my patients. And disclosure, I am not an allergist or immunologist. I am but a humble neurologist. But the way I talk about mast cells is they are part of our immune system and our allergy system, and they're meant to do good things. If I cut my finger, mast cells are some of the first cells that are there to release chemicals that attract white blood cells to fight infection, to attract platelets to clot off the wound. But in some people, mast cells are releasing inappropriate excessive chemicals, histamines, et cetera, that cause more inflammation in the body. And that's a key word that we're saying through this whole conference, right, is inflammation, excessive inflammation. And that's disruptive to the autonomic nervous system. And so that's why some people will benefit from things like antihistamine therapy to kind of block some of that inflammation. And their autonomic nervous system will therefore benefit from some of that reduced inflammation. It can therefore benefit some of their POTS-related symptoms, maybe some of their migraine-related symptoms as well.
Thank you. And a couple of things that both of you guys have mentioned, and even in the prior panel, is there's all these different conditions, but not everyone has all of them. That's important to keep in mind. It's also important to understand why that happens, right? It's the genetic heterogeneity. So in the most recent genetic studies of migraine, it's like over 120 different locations in the DNA that may have mutations. And remember, individual people may not have just one of those, they may have a different combination. So I'm not a mathematician, but someone in the audience can determine what are the multiple different possibilities of those combination of 123 loci that could have a mutation. So there is a vast amount of genetic heterogeneity or diversity or possibilities, and that is what leads to everyone's migraine experience being very, very different, everyone's different comorbidities being very, very different. It also explains why all of our medications don't work in every individual person. Patients often ask me, like, Dr. Starling, you're good, but not that good, because why can't you figure out which medication is going to work for me? And that's because we don't yet have personalized medicine. Gosh, we're hoping we get there, hopefully in our lifetime, with a lot of the big data analysis, but we don't have right now, something that's going to be a blood test or an imaging study or a saliva sample that will tell me, based on your genetic combination that's leading to this vulnerability of migraine and all the other comorbidities, that this medication is going to work for you, this one's not, this one's going to give you side effects. All we have now are many, many clinical trials that have shown in these clinical trials that about 50% of people, 50 to 60% of people have had at least a 50% reduction in their migraine days. That's what we have. And that's because of this genetic heterogeneity. And I think it's really important. My initial consult, I'm always very transparent about that with our patients. And I always tell my patients, so my initial plan for you may not be effective, but I need you to understand why so that you come back to me. So don't give up on me. Don't say, well, yeah, I went to Starling. People said she was good. She gave me some options. It didn't work. I'm not going back. And they disengage from the healthcare system, right? And so I think it's very important for me to be transparent and be like, the first thing I give you will likely not be effective. I'm trying based on X, Y, and Z. That's why I've chosen this treatment regimen. But it may not work, and I need you to come back and we'll talk about why it didn't work, and then we'll come up with the next plan. But it really takes a work in progress and a journey. And then it makes it more difficult because things change over time with the hormonal changes and just other comorbidities, other hits. And so what worked 10 years ago may not work today. And so we have to kind of continue to work together. But I love how you made people take deep breaths. I also was holding my breath. But what I want to end it with is, we've talked about all these different things and mentioned how one of us is not going to be able to address all these things. So often it feels like for patients very overwhelming. They have all these symptoms. They don't even know who is the one person who's supposed to take care of these symptoms. There isn't actually one person who does it. And so there's this huge fragmentation of care. And so you see a lot of these patients, Dr. Arca. What is like your framework to empower these patients who feel so overwhelmed by the plethora of symptoms and the fragmentation of the healthcare delivery system?
Yeah, it's definitely overwhelming, and oftentimes by the time a patient is seeing me, they've probably seen 5 or 6 other specialists. Unfortunately, by that time, have been told it's all in your head, or it's anxiety, or whatever else. And it might be the first time that they've actually maybe been able to get out all of their symptoms. That being said, as a neurologist, I'm probably not the one that can address everything. And so I like to work in this framework of pieces of a puzzle. And we might not even know what the full puzzle looks like yet. But we want to look at each of these pieces of the puzzle, and I like to work with the patient to try to figure out, well, which piece of the puzzle is the most important for us to address right now. And so what piece of the puzzle in the first visit might be different piece of the puzzle in the second, third, fourth, fifth visit, whichever. And sometimes as the patient, that also might be hard for you to identify because, you're like, well, I've got these 20 plus symptoms. They're all bothersome to me. And that's, where it's our job to work with you as well. Even I can actually just think about a patient I just saw this last week who was in this situation and was describing to me lots of different things. And she really didn't know where to start. And I kind of picked up on one thing that I felt like seemed the most debilitating to her, and that's where we decided to start. And in that case, it was more vestibular migraine symptoms. So that's where we decided to start with her. Yes, there were also POTS symptoms. There were lots of other things, but we decided to start with the vestibular migraine. So I think that is kind of the route that I usually take, and probably a lot of us take with our patients, is just trying to take one piece of the puzzle at a time.
Yeah, I really like that. I know Dr. Vanderploem, who wasn't here today, and you always talk about the puzzle, which I might switch to that. I always talk about this peeling of the onion. I'm like, let's peel the onion, but maybe that's a bit of a smelly analogy. So maybe the puzzle and not knowing what the picture is more appealing. I'm going to borrow that. Dr. Townsend, what I'd like to end the panel with before we move on to questions is what are some evidence-based self-care practices that can actually help with this overwhelming, I have so many things, I have so many doctors, and how do I move forward?
Absolutely. In my previous kind of conversation to kind of then kind of pull to this point is central sensitization, which causes nociplastic pain, is known as a psychoneuroendocrine immunological response, which is a mouthful. I've practiced that one a lot, which is this way of saying all the threat response systems in your body work together to protect you. Psychoneuroendocrine immunological response. It's only a matter of time before we throw gastrointestinal and cardiovascular. So by the next time we speak, that will already be part of the name because they're all involved. That's why a comprehensive approach has to be taken. Because a number of times certain medications can work. What I tend to see as a behavioral psychologist, as soon as I feel well, oh good, let me go back to that unhealthy lifestyle. And I'm like, no, that's not where we're supposed to do. Part of it is the first part that I'll always encourage everyone to is a word that people generally don't like, but it's so important, acceptance. And it's not a passive, resigned, helpless acceptance. It's an empowered acceptance, a part that says, listen, I have migraine disease. My whole nervous system, maybe since even before I was born, but certainly in my lifetime, has become efficient at something. I need to protect it. What does that look like as I move forward? All right, so when we think it from that standpoint, just like, again, if you have diabetes, you don't manage your diabetes well by pretending you don't have it. You say, I have it, I'm going to learn about it, and I'm going to create a lifestyle where I'm going to intentionally start to engage the changes that I need to use. Cognitive behavior therapy is one way of being aware of our thoughts, our behaviors, our actions, specifically as it responds to pain, but also other areas of our life. So oftentimes people use relaxation training. I certainly do yoga, Tai Chi. I like the Belly Bio app. It's a way of doing your own biofeedback. Except for my perfectionist will get perfect at the breathing, so calm down. Make sure your brain calms as you're also engaging great rhythmic breathing. Being able to pick what you're going to start to change in your life, do it for a week, and then see what gets in the way of it. And that's what you need to target next. Maybe it's guilt. But I want to help other people, and then the idea of saying no to someone. Maybe it's me trying to please and do everything for all people, excluding my own self-care. So self-care should move beyond the idea of pedicures and kind of, scents and beautiful things and think those are lovely. I consider those the self-care light things. I love them. Pinterest has tons of ideas about them. Sometimes I consider self-care to be having a hard conversation with someone that you'd rather avoid. To be able to set an appropriate boundary, to be able to have a conversation with yourself, because this is a part that often people don't talk about in the context of well-being and finding your peace and calm is what is disturbing it gets louder. And guess what? You have to go tackle that one next. And you're like, I don't know if I want to do that. I'm like, I know, you've been avoiding it for a really, really long time. It's time. What are the resources you need within and around you to help determine how to start to engage those important changes in your life? And sometimes that acceptance means your environment itself, it's not healthy. Sometimes it's how you talk to yourself. I'll hear people talk to themselves. I'm like, that is the cruelest thing I've ever heard anyone say to another person. It just so happens to be you talking to yourself. Can we talk about that? Can we understand where that started and where it needs to go? Because our brain does, as it pain, danger signals, threats, cruelty that we say to ourselves is also part of that. Some of the people that are kindest to everyone in the room except for themselves. I see that quite regularly. Those are just some of the pieces and how we put them together, again, for a lifestyle approach.
Thank you so much. I guess we don't have time for questions, but I just wanted to thank the panel. And I feel like a summary of this is how efficient our systems have become and how we need to protect the beautiful, efficient system so that it's actually serving ourselves, serving our health, serving our wellness. I love that you mentioned also that it's more about figuring out what it is for each individual person, because it may not be mindfulness, it may not be a spa day, it may not be all these other things for everybody, right? But we have to figure out what works for ourselves. So I love that. So thank you so much for your attention, and I think we move on to the next panel. Or do we have a break? I don't know. Oh, we have a break.